talk and start the discussion on the equipment in the sleep lab, and that's actually what we're going to start this week in lab as well, is how to start applying those electrodes. So I don't know if you noticed on Blackboard the little note about this week's lab to pay attention to is wear loose fitting sweatpants. Even though leggings are stretchy, they're not sweatpants. And what's going to happen is you're going to drop the leads down your clothes and down your pant leg until it gets to about your shin. So when you're wearing tight pants, it's very awkward getting it down there. It's normally a very discreet process that we have our patients, because they're normally wearing pajamas, which are loose and comfy, whatever, where they just drop them straight down, and that's to hold the wires against their body so that they don't tangle themselves in them. So that being said, if you're still celebrating No Shave November, we will be applying electrodes to the legs. You don't need to shave above the knee. You don't have to shave at all, honestly, because who gives a crap? But if that's something that you're embarrassed about, I'm giving you the warning now that we will be applying electrodes to the legs, just on the shins, just not above the knees or anything. All right, so let's talk about the equipment. Let's first start by talking about what a sleep study is, because probably a lot of you don't even have that necessarily background of what is a sleep study. You're in this program to learn how to conduct one. So let's start there. So it's basically an evaluation of how well a person sleeps. We try to mimic the patient's home setting and scenario as best as possible. It's non-invasive, so everything is external. There's nothing that is applied internally or invasively, no needles, nothing like that. It's literally stickers and paste that we put all over the patient's body. We then are able to record a lot of data. We're able to see a lot of different things and patient parameters to kind of put together a really good idea of what's going on throughout the night for the patient. How they're sleeping. Are they getting the quality of sleep that they need? If they are they getting enough sleep? All of that. So the polysomnogram is the actual recording, the actual sleep study. A polysomnograph is the device that we use to record the sleep study. So a little difference in the terminology. We're looking at a bunch of different types of channels. We're looking at them all simultaneously so we can correlate what's going on with the patient. So if they're all of a sudden we see them wake up in their brain waves, there's a change in their brain waves. Well, what caused it? Did they kick? Did they snore? Did they stop breathing? Did it cause a change in their heart rhythm? Sometimes, it can cause a little bit of tachycardia. Sometimes it can cause them to have a missed beat, all of that. So we're able to kind of put it together so we view everything simultaneously so we can really put together the story of what's going on. We generally view the sleep study in a 30-second increment. So every window that we're looking at it's 30 seconds long. And that's referred to as an epic. So I throw that in there because if you hear me say epics again, you've at least been introduced to that term. So the standard epic is 30 seconds. A lot of the principles that we go by are relating back to the analog days of the old pen and paper systems. Thankfully, you'll never come across, well, I won't say never, but the likelihood that you'll come across the old analog pen and paper systems of running a sleep study are so few and far between. I've never even seen one, but I think they are still around for like demonstration purposes. But all of our terminology, our calibrations, like all of kind of the fundamentals of how to run a study will date back to the old pen and paper systems. And when I say that, think of like an old school style lie detector that you see on the TV with the pens going across like the paper as the paper continuously feeds through. That's similar to how they used to do sleep studies like way back in the day before it was all digitized. So a single sleep study would be like 1,000 pages of paper. Could you imagine having to sift through that to like review all that data and tabulate it all up? I couldn't even imagine. So that's when we say paper speed is how quickly or what the time base is that we're looking at when we view a sleep study. So we're looking at 30 seconds a page, or that's the time base, 30 seconds on a single epic, but how quickly that paper is fed across the screen to get to that is 10 millimeters a second. So again, there's a lot of these old school style principles that you're gonna just have to learn and unfortunately just commit to memory. Here's the PowerPoint. So in terms of all the different things that we're looking at, we look at the EEG or electroencephalogram, that's your brain waves. We want to look at the heart rate and rhythm. We do that through the EKG or ECG, depending on how young you are. We monitor the patient's eye movements with electrooculogram electrodes, or they're abbreviated as EOG. We monitor the patient's muscle tension or muscle tone through electromyography. We monitor that in two different places, on the legs and on the chin. The legs monitor if the patient kicks at all throughout the night, so restless leg syndrome, stuff like that. The chin picks up if they grind their teeth at all throughout the night. It also is what we're able to gauge the overall bodily muscle tone on. We monitor the patient's breathing through a couple different sensors underneath their nose and their mouth. One gauges the temperature, so it's called a thermocouple. You also might see it referred to as a thermistor, but if you see the word therm, T-H-E-R-M, it really, just think of temperature picking up the temperature difference as a person breathes in and out. And then the pressure transducer looks just like an oxygen cannula. It's just nothing's coming from it. It picks up the patient's breathing and it'll pick up the pressure differences as they breathe in and out. So we use those two sensors together to, actually, no, I can actually get rid of you can do that. We use those two sensors together to pick up the patient's breathing. Breathing effort is monitored through two belts. One goes around the chest, one around the stomach, and it just picks up the movement as they breathe. We monitor their oxygen level through the SAT probe on the finger, but we have one that's tied into our system. So it's not like the little plastic ones that you guys have for your kits. That's for spot checking an oxygen level. But for a continuous monitoring, we have a softer one. It's usually pretty flexible. Surprisingly enough, the SAT probe is the thing that patients complain about the most. We're putting on upwards of 30 wires, some odd wires on the patient. The one on the finger is the one that bothers them the most. And that's because we just have so many nerve endings on our fingers that, it can start to feel, you don't realize like how sensitive your fingers are until you have something compressing on it for hours. So, because they can get sweaty, it starts to feel heavy, starts to feel like achy, or you can start to really feel your pulse. So anytime the patient gets up to use the bathroom, I'll switch which one I have it on because it's just can get really aggravating. We monitor their snoring through a sensor that goes on their neck. Generally, the most common version that we use is the one that picks up the vibration of the snoring, but there are snore microphones, which are legit microphones that pick up the sound, but they're a lot more delicate of a technology in terms of cleaning and the maintenance of them. So the snore sensors, the ones that pick up the vibration, are a lot sturdier of an actual sensor, that they last a lot longer. So most labs use the snore sensors that pick up the vibration. And then for pediatric studies, we'll do an additional parameter of monitoring end-tidal CO2, which is their exhaled level of carbon dioxide. We need that additional monitoring in place for pediatrics because their breathing issues tend to be less obvious, more minute. So we need a more sensitive way to pick up those very kind of slight breathing changes that can happen in the pediatric population. All of this goes together to tell a really good story. So the main purpose of the sleep study, and this is actually how I'll explain it to the patient. I'm going to put a lot of different wires on you, and the main purpose is to see the quality of sleep that you're getting, how deep of a sleep you're getting, the kind of quality of sleep you're getting. Are you getting into the deeper stages of sleep? And if you are you getting enough of it? The head wires are the ones that are going to tell me what stage of sleep that you're in, the ones that go on your scalp and on your face. So the ones that monitor the brain waves, the eye movements, and the chin. The rest of the wires are going to tell me what's going on to potentially disrupt your sleep or keep you from getting into those deeper stages of sleep that are so important. Are you stopping breathing? Are you having issues with your breathing? That's where the belts and the respiratory sensors come in. Are you snoring? That's where we've got a snore sensor. Are you having trouble with, is it impacting your heart throughout the night? We're monitoring your heart. Are you kicking at all? We're monitoring the legs. And we're monitoring your oxygen, so how it all impacts the patient together as a whole. So this is a sample epic of what it looks like. It's a little blurry, but it's pretty much, it's got everything on it that we monitor. Like I said, we're going to look at it all consecutively. So it really will tell the story of what's going on with the patient. And that's the purpose of this course, is to start learning how to read that story about what's going on with our patient, how to put the stuff on to be able to get to this point to see it, and then to also start to how to interpret all of the data that we're looking at. So what you're looking at is you've got the eye movements here, these two top ones here. This is your left eye and right eye. Your muscle tone here, so you might see a little changes as the patient's, tension level increases, decreases, whatever. Brain waves, heart, the legs, all the different breathing channels that we have, oxygenation, pulse rate. So it all goes together, and it looks like a lot at first, but you'll be able to start to train your eyes and pick apart what you're looking at. One of the things that kind of commit to memory as well is that when we're looking at a recording, a negative wave is represented by an upward pen deflection. So when you see the line on the screen, and I say pen deflection because again, it all relates back to analog. But when the lines that you're looking at start to go up, that means it's a negative wave. It's a negative value that it's representing that it's picking up from the patient. When we're looking at, when we see the pen start to go down or the line on the screen start to go down, like in the brain waves and stuff, that means you're seeing a positive deflection. So everything that's being displayed on the computer screen is a reflection of all these different biological or electrical potentials that it's picking up from the patient. And so what's happening then is the different voltages that it's picking up from the brain waves, that it's picking up from the eye movements, it's being reflected on our screen. And so we're going to talk a lot about kind of the electronics end of it, kind of the background of that. But when you're looking at it and when we start to pick apart how to read the waves, the voltages that are negative are represented by an upward pen deflection. So it's kind of opposite than what you'd expect. Electroencephalography. You want to practice saying that? Electroencephalography. It's important that you not only know, I mean, it's so easy to just start, oh, EEG. You got to know what it stands for. You got to know the terms that you're actually doing here. So EEG is short for electroencephalography. That's the brain waves. That's the electrodes that go on the scalp to detect different electro neurofirings of your neurons. It's not picking up the firings of like individual neurons, but more of a collection of neurons, because you think of how tiny neurons are. So, and the electrodes are about the size of like a pencil eraser that are placed. So it's picking up the accumulation of what is going on in that specific area of the brain. They're pretty quick signals that we see. They alternate between positive and negative very quickly, really depending on the state that the patient's in, whether they're awake, whether they're relaxed, whether they're asleep, specifically what stage of sleep they are. And that'll be another huge component of this course, is learning how to read those brain waves to determine what stage of sleep the patient's in, by looking at the height of the wave, how fast they're coming through, what shape they're taking on. There's another example of what it looks like. I know the picture is kind of blurry, but again, it's one thing we'll spend a lot of time on, is learning how to pick those up. Electrooculography is the recording of the eye movements. It's abbreviated as EOG, but again, make sure you actually learn the terms behind it. Electrooculography Essentially what we're doing is we're placing electrodes just outside the outer canthus or corner of the eye. So if you find like the outer corner, and then you're going to go about a centimeter out and a centimeter up and down. We're going to deviate them. One's going to be a little bit lower, one's going to be slightly closer or higher. And that's so that way we can more easily detect what direction the patient's looking in based on the positive or negative deflections that we're seeing on the screen. You want to place the electrodes, you want to really avoid the very sensitive skin around the eyes because, you know, I'm getting older, like that's sensitive skin. You don't want tape on it. You don't want the paste like squeezing into the patient's eye. Sorry, this is really throwing me off. And this is getting hot. It's like, oh, I don't have to wear the things today. Oh yeah, okay. Sometimes like, you know, when you're talking and you're like going at a good clip and it's like, just gotta kind of take a break for a minute. Eyes. That's one of the nice things about recording through Tech Relay is I can just pause it when I need to take like a mental minute and walk away. Okay, I got this. Eyes. So we want to put them as close as possible to the outer corner of the eye as without really going too close and being on that very sensitive skin. You've got to kind of use the space you have based on the patient. You know, eyebrows are a really important thing right now. I do not tape over eyebrows. You want to be really careful about those, especially those like little baby hairs that are around the face. You don't tape on those. So you just got to use the space that you got with, you know, when you're looking at the patient. What we use the eyelids for is they're important that we can see when the patient's blinking, when they're awake. The brain waves look very different from when a patient is awake when their eyes are open versus when their eyes are closed. The brain waves look also a lot different from when a patient's alert and actually mentally concentrating on something versus when they're relaxed. So one of the ways that you know when the patient's definitely awake is you can see the eye blinks. It's kind of reflected. When you start to fall asleep, what happens is your eyes start to kind of roll back in your head and they kind of lollygag in your head a little bit. And you get this like slow rolling eye motion. That happens to everybody. Like watch anybody start to fall asleep. Like in about 20 minutes, everybody look at Spencer because you're going to watch his eyes start to kind of go up a little bit in the back of his head as he starts to fall asleep. Everybody does that. Look at your dogs, the babies, whatever. And that's one of the ways we can tell. It's one of the indicators when a person is starting to fall asleep is you get that slow rolling eye motion across the screen. And you can see it when they're still awake and you know that they're about to fall asleep really soon or right as they transition from wake to sleep. You can see that kind of crazy rolling of the eyes. REM, stage R, sometimes you'll see it as R, REM, rapid eye movement sleep. That's when we do the majority of our dreaming. And it's named for what happens, rapid eye movement. It actually, that's what's happening with your eyes. Your eyes are just like going crazy all in your head, like looking all over back and forth. And that's one of the stipulations that we need to see in order to be like, yep, this person's in REM, is you see these like crazy eye movements of REM. So that's what it looks like. You have EOGL, so that would be your left eye. EOGR, that's your right eye. So you can see as the person's looking around, you know, that could be indicative of, this is like very similar to what you actually see when they're in REM, is these crazy crisscrossing eyes looking all around. So you got these very like jutting and sharp lines here. So the cornea is positively charged with respect to the retina. This is like one of those, again, I don't know if you guys keep flashcards or whatever, but like these little facts, I don't know why they love to ask you them on the boards. So that kind of explains why we see what we see when the patient looks certain ways, is because of the electrical charge of the eye. So basically what happens is you have two eye electrodes. Remember, they're offset, one higher, one lower. When I look to the right and I look towards the right eye electrode, you're going to see a positive or a downward deflection on my right eye electrode and a negative or upward deflection on the left eye electrode. Make sense? When I look to the left, not with my head, but with my eyes, you're going to see a positive or downward deflection on my left eye electrode and an upward or negative, because I'm looking away from the right eye, on this one. Make sense? Now remember, they're offset, left lower. Left goes a little bit lower, right's a little bit higher. And I'm like exaggerating it here for the purpose of just showing you. When I look up, I am looking more towards my right eye, because this one's the right eye electrode, because this one's upper. So you're going to see a positive or downward deflection on the right eye electrode and a negative or upward deflection on the left eye. When I look down, you're going to see a positive or downward deflection on the left eye electrode and a negative or upward deflection on the right eye. And you'll see that on the screen. All right, so if this is the left eye, this is the right eye. You're seeing it go down, which means it is positive, so I'm looking towards my left. You're seeing this one go up, which means it's negative, so I'm looking away from my right. See how you can kind of track those eye movements? It's just, again, it goes back to a positive deflection is represented by a downward wave. Just gotta think it's the opposite of what you expect it to be. So this is what I just explained. You can kind of track your way through it. Electromyography, or the recording of muscle activity and tone. We're basically identifying certain muscle groups that we apply these electrodes to. And what we're looking at in these channels is we're not seeing these like sharp waves like you see in the eye channel, but instead you're kind of just looking at a solid line. And so when the person gets more tense, that line thickens. And when they relax, that line thins. Those changes can be abrupt, like all of a sudden they tense up and you see this abrupt change in the thickness of the line. It can be subtle, like as they're falling asleep, you see a gradual drop in the muscle tone as they fall asleep. So that's how you're reading these signals, whether we're looking at the chin or the leg leads, because remember we monitor the muscle tone in two different spots, on the chin and on the legs. So you're just really looking at the change in the amplitude. Here's an example. So slight increase in muscle tone, even bigger increase in muscle tone, and a really big increase in muscle tone. These are abrupt changes. You can also be more gradual, like all of a sudden they're waking up and you see it come up, or all of a sudden they're falling asleep and you see it gradually drop off as well. The ones that we apply on the chin or the jaw area, they're really, like how I explain it to the patient is like, oh, if you clench your teeth, I'll be able to see it. I really just don't want to get into the real purpose of them. Like, yes, we're looking at them to see if the patients clench their jaw or anything like that. But the main reason we put the ones on the chin are those are the ones that we kind of gauge the overall bodily muscle tone with. We're able to see, you know, what their tone is and help to gauge that based on their, to determine what stage of sleep they're in. Generally, when we start learning the different stages of sleep, there's a lot of generalizations. Usually the muscle tone goes a little bit further, the deeper sleep they're in. That's typically what we expect to see. And it kind of helps us to determine like, or reinforce like, yeah, that's what I'm seeing on the brain waves. But for REM, what happens during REM is that's when your bodily muscle tone is at its absolute lowest. You are in a state of paralysis or muscle atonia during REM sleep, rapid eye movement. Any guess as to why? You got it. Yeah. When people that act out their dreams, there's some defect in that paralyzation that's happening. And so when somebody is to act out their dreams, it's actually a really dangerous disorder. Usually most patients that come into the sleep lab that have this, it's called REM behavior disorder, are coming in because they're injured. They've injured themselves, they've injured their bed partner. That's usually what brings them in. Like I remember the worst case I ever saw was I had this dude come in and his foot was in this giant cast. And we don't normally do a sleep study when a person has an acute injury or illness because it's not going to give us an accurate picture of what they're going to do on a normal night's sleep. But then I started talking to the guy, like, what's going on? and his wife made him sleep on the couch because he punched her a few too many times in sleep. And it was the type of couch that had the wooden end, and he put his foot through it. And so that's what brought him finally to the sleep lab. Not the fact that he punched his wife, but he hurt himself. So we monitor the leg electrodes to pick up if patients are kicking at all throughout the night. Leg kicks are more common than you would ever know. And that's why we put them on every patient. So pretty much the array of wires that we put on our patient is the same regardless of what the patient is coming in with in terms of their history, what we read in their chart. We're not gonna, I mean, there's a few specialty things that we can add on, but the array of wires that we apply is pretty much standard for every patient because you truly don't know what you're going to find until you start running the study. And that's the same importance for leg movements. Oftentimes people will kick a lot throughout the night and not even realize it, like, because it could be, it might not be waking them up. It might not be these very obvious overt leg kicks where it's something that their bed partner can say, like, yeah, you kick like a horse all night. It could be even as little as like just their muscle tensing, but we're going to pick that up. And that could be enough that could disrupt their sleep. They just might not have any realization that it's happening. So here's an example of like leg kicks. You got the leg, right leg, left leg. And so leg kicks can be symmetric, where they're happening on both sides. They can be unilateral, where they're happening mainly on one side. They can alternate. That's why we put them on both sides. You just never know. You never know, because, and I read one study too, where they found that people that do have leg kicks, it tends to alternate night to night, where on one night they might have like a left leg predominance, and then the next night they have a right leg predominance. So we put electrodes on both legs because you never know which way they're going to kick. And then you can see the muscle tone come up periodically throughout the night. And it can correlate with either if they're awakening, if they're having arousals, it can correlate to a lot of different things. Where we apply the electrodes, and I think these pictures are from your textbook. The leg ones go on the anterior tibialis muscle. So I don't know if did you guys learn the muscles in docs class or no, because you're not x-raying. Well, you only have to know a couple muscles, which is good. You don't have to know the whole body. But for the legs, it's the anterior tibialis, which if we were to look at like the muscle group that it's placed on, it essentially runs parallel to the shin bone, that muscle. And so if you were to feel your leg, feel your calf, find your shin bone, and what you can do is just point and flex your leg up and down, and you'll really feel it flex. The other way to find it in a more discrete way, because that actually causes large muscle changes, muscle tone changes on your leg, not just the anterior tibialis, but feel the same for the same muscle and just wiggle your toes. That's also going to cause that muscle to kind of flex. The chin ones are placed on the mentalis submentalis muscle, which is right above and below your jaw. So you want to avoid the bone. You're not placing them right on the bone. You want to try to place them just above that, like the rim of the jaw, right above it, and then right below it as well. It's important, the placement, in terms of being kind of symmetric with how and where we're placing them. You want each of them to be about 2 centimeters apart. So you're pretty much creating a triangle on the jaw, on the chin there. Same thing with the leg leads. They're going to be about 2 centimeters apart. And the size of the stickers that you're using to place those will kind of determine the size of those that you're putting them on. The reason why we have to be fairly strict with the placement is when you go really far out, when you're placing them like on the outer side of the jaw, or like really spread them out on the legs, what's happening is electrically, you're not going to get as good of a signal, because all of these electrodes needs to reference to each other in order to create the signal that we see on the computer screen. You don't want them too close where they're pretty much right on top of each other, because electrically that's not going to do you any good. But if they're too far apart, you've got to think of that signal has to travel through that much bodily matter to pick up the other one to create the signal that we're seeing on our computer screen. So you're going to get a lot more artifact. You're going to get a lot more extra in the signal other than what we want to see, which is the muscle tone. So for the most accurate recording, you're gonna learn how to be fairly precise and, you know, kind of eyeballing what 2 centimeters is for the placement of your chin and for your legs. Sometimes we'll add additional electrodes on the arms. This is not standard, but sometimes it's added in if we do have somebody that has any type of movement disorder, like REM behavior disorder. If they're acting out their dreams, you kind of like find the one arm muscle and put them on the arms, and then we can see if they're acting out their dreams more. It kind of just gives us a little extra information. Or if they have really severe restless leg, because sometimes restless legs, even though the name is restless legs, in patients that are really severe, it can extend into their arms. And so in those instances, the physician might request that we add additional electrodes to the arms. EKG, electrocardiogram, we're recording activity from the heart. If you have not taken EKG yet, the latest that you'll be taking it is in the summer. I will say don't throw your stuff out or sell your book back, because this is something we'll keep coming back to throughout your clinical year as well. But essentially we do not a mini version, but we do a condensed version of the EKG. We're not doing 12 leads. Most setups take 2 or 3 leads to monitor the patient's heart. There are certain things that, you know, it's a lot of stuff on the patient and stuff does get knocked off. There's certain things that we can kind of do without, you know, okay, if they knock off one of the brain waves, like we got a bunch of others that we can pretty much see what's going on with the patient. The EKG is one of the ones that we cannot go without a constant reading, accurate reading throughout the night. And that's for the patient's safety. So if something happens, we're not getting a good reading, we need to go in there. It doesn't matter if it's to the detriment of the patient's sleep. We got to wake them up. We got to fix it. And there's been instances too where I've had patients cancel the sleep study and be like, I'm done, take this stuff off of me, but I'm not leaving until my so-and-so comes and picks me up in the morning. I'm sleeping here. Like they treat it like a hotel. I go, okay, but I can't take everything off. While you're in this building, you're under my care, under my responsibility. I have to continue to monitor your heart and your oxygenation. So even if and that's happened. And some labs, I don't know, it depends also like how lenient your lab is that allow it, but sometimes you just don't even have a choice. Like the patients refuse to keep everything on, but they also refuse to leave, or they can't leave until a ride comes for them in the morning, and they have nowhere else to go. Especially COVID, it's not like you make them sit in the lobby or anything. So, but yeah, we have to monitor it at all times. Oxygenation, a non-invasive way to monitor the patient's oxygenation and their pulse. And it works by estimating how much hemoglobin is in the blood that's saturated by oxygen, displayed as a percentage. Higher the percentage, the higher the level of oxygen in their blood. Basically how it works is the one side of the sensor sends the light through to the other side, and the other side is what reads how much oxygen is riding on that blood. So what can happen is, especially in this weather, if fingers are really cold, circulation isn't so great, you might not get a more accurate reading. You know, so if you see a reading that it doesn't seem, you know, that doesn't seem accurate, speak up. Don't just go with whatever you're seeing. Try switching fingers. Actually feel the patient's hand. Is it warm? See, like, you know, we've had a lot of issues with the oximeters that came in your kit. You know, if you don't agree with the reading, if the patient's sitting in the 80s and their color is fantastic, yeah, I probably wouldn't believe that reading. Try getting a different finger, switch probes, whatever you've got to do. The other thing that can impact the accuracy of this reading is fake nails, nail polish, especially in dark nails. I think that like shellac, or is it the dip nail polish? That really impacts it, to the point that I know one lab, if you show up and you have those on, they send you right back home. They're not even going to attempt to do a sleep study on you, because it's such an important part of the study. We need an accurate oximeter reading consistently throughout the night. So like I said, when a patient, they say they refuse to the wires and they just want to sleep there and use the lab as a hotel for the rest of the night, they canceled their study. We need to monitor the EKG and we need to monitor their SAT. That's the two that are just like, for safety, we have to monitor at all times. Respiratory channels. Any questions so far? If you guys need a break, let me know. Go ahead. I don't think I've ever worded it in a place in a way that they could refuse, if that makes any sense. For what? No, they can go home. It's an outpatient study. You don't like it, I'll see you. I've had patients refuse because they didn't want to mess up their hair. Like they just had a new weave put in, and weaves are expensive, and they didn't realize that I was gonna be pasting them all up. So I said, all right, come back, make the appointment when you're ready for your next hair appointment. I've had patients refuse because we wouldn't let them drink. But usually that doesn't stop them too much. They just go out in the parking lot and then come back in. You've obviously never worked with people if you're giving me that face. Nothing surprises me anymore. Okay, so if you guys do need a break, let me know. Otherwise, I tend to just kind of barrel through and we can get out of here a little quicker. But if you need a break, just let me know. All right, so we monitor the breathing through a few different things. The airflow is with the airflow sensors. So you have the thermistor, thermocouple. Again, if you just underlie therm, it means temperature. We're picking up the temperature difference as their breath changes from inhalation to exhalation. And then the pressure transducer is picking up the pressure difference as they're breathing in and out. And then the respiratory effort is monitored by two different belts, one across the chest and one around the stomach. And it's just picking up the movement as a person breathes. So the frequency of the respiratory rate, what's one of the beautiful things that once we're running a study, there's a lot of the basic vitals that we're able to just continuously see from all of the things that we put on the patient. So the respiratory rate, you're really just looking at the frequency of that waveform. So the faster the wave, the quicker the respiratory rate is. Slower the wave, the slower the respiratory rate is. So you basically would count how many waves. So 1, 2. And then if we know a single epic is 30 seconds, however many breaths you counted in that single epic, double it or count for a full minute, whatever. The amplitude of the wave is determined by the volume of air that they're breathing in. So the bigger breath they breathe in, the bigger the wave is going to be. The more shallow the breath, the more shallow you're going to see that reflected. Notice the frequency, though, is the same for each of these three different examples. So the rate of the respiratory rate is the same. Here's another example of kind of going back to that full epic where we're looking at everything. There's your respiratory channel. So again, it's a very kind of more of a slowly oscillating channel reflecting the patient's breathing. You can see changes in their breathing. They're breathing kind of normal here, and then you see it kind of dissipates a little bit here, and then a little bit of a kick and wake up. So in all likelihood, what's happening is they're having some type of respiratory event that's causing them to wake up. So their airway might be closing up a little bit on itself. That's causing their breath to be dampened, and then they wake themselves up. And when they wake up, their airway returns and they're able to breathe normally. Sometimes you'll see them breathe a little bit quicker to kind of blow off the CO2 that accumulated, and then they fall back asleep, and it kind of, so some of our patients, that's pretty much what we look at. As soon as they fall asleep, their breathing starts to become obstructed, they wake themselves up, comes back, and it's that constant like issue with their breathing, wake up, recovery, fall back asleep, and it's like just non-stop. You know, you can see somebody have stop breathing upwards of 100 times an hour. 100 times an hour is or more we can see with our patients. Here's another example. You've got all the different respiratory channels. They typically go in line with each other. They're all reflecting the patient's breath, but in a different capacity. Again, the thermal sensor is picking up the temperature difference. The pressure transducer is picking up the pressure difference as they breathe. And then the belts are picking up their effort to breathe. So sometimes, like if a patient's having an apnea, which is where they stop breathing, you'll see a mismatch in what's happening between what we're picking up with our flow sensors and what we're picking up with their effort to breathe. Like for instance, with an obstructive apnea, you still see an effort to breathe in your belts, but you won't see any movement in your flow sensors underneath the nose because their airway is closed up. They're essentially choking themselves. You know, somebody's coming up and strangling them, but it's really just their own body. And, you know, so they can't get past air to breathe, but they're still trying to breathe and they still struggle to breathe, and it ultimately results in them waking up. So thermocouple thermistor, it's a temperature-based device that's picking up what's happening with the patient's breathing. It doesn't, regardless of the actual technology that we're using, whether you're using a thermocouple or a thermistor, how it looks on our computer screen is identical. It basically picks up the airflow at the nostrils and the mouth. So each of them will have this little funny looking kind of piece that goes in front of the nose and a little funny little hook or hoop that hangs in front of the mouth. It's not invasive. We're not like sticking it up their nose, and it's temperature based. So I don't even want it in their nose. I don't want it really even touching their skin. I usually have it kind of like hanging out right in front of their nostrils. So it's not necessarily touching their skin because I don't want it. I want it to just pick up the temperature difference as they're breathing in and out. And it doesn't go inside their mouth because ew, and it just get all drooly. And again, we're picking up temperature of their breath, not of their spit. So the difference technology-wise between a thermocouple and a thermistor is really how it works. A thermistor uses a battery. And so if you're starting to have issues in your signal, if you see a little battery pack on it, you know it's a thermistor and it would probably require the battery to be changed. Unfortunately, this is a sensor that we typically do have some issues with. They tend to die a little bit quicker than our other sensors. So you need to know whether or not changing the battery is an option. If it's a thermistor, there's a battery pack, you can try changing the battery. The thermocouple uses two dissimilar metals to generate its own electricity. And that's how it works, is it doesn't have a battery. It just, how it was built is with two dissimilar metals, and it uses like a piezoelectric crystal to generate its own electricity. So that's how you can tell the difference between the two, whether or not there's a battery. If there's a battery, it's a thermistor. If there's no battery, it's a thermocouple. How I remember which one's which is I think couple two dissimilar metals, couple two. But this is some examples of what it looks like. We have this one back in the lab. This would be the kind of the bar that hangs in front of the nose. This is the bar that kind of hangs in front of the mouth. You got these two little prongs again that kind of hang just in front of the nostrils, and then you kind of loop and can bend this so it's right in front of the mouth. Same thing with this. The pressure transducer can look exactly like an oxygen cannula, you know, where somebody might be getting oxygen from it, only it's not. It could be, but the end is not connected to oxygen. And I always explain that to the patient because they always think we're putting oxygen on them for the sleep study. And so as I'm putting them on that, or when I'm explaining it, I'll tell them nothing is coming from this. It's just picking up what you're breathing in and out. And so what's happening is the air that they're exhaling is they breathe it into the cannula, and it is connected to this little thing at the end. It's like, that's the actual technology of it, is this little box that we plug into our system. And it's picking up the pressure difference as they breathe in and out. We use two different types of flow sensors for the patient because they each can give us their own info in their own right. The temperature-based one is more of a broad look at their breathing pattern. You know, we kind of just see the structure of their breathing pattern. Apneas, when they stop breathing, become very obvious in that channel. The pressure transducer is more of a sensitive device where we can look at the shape of the waveform more. Like if it starts to take off a squaring appearance, we know that they're hitting a little bit of upper airway resistance. So we can start learning how to read the shape of that waveform. So less obvious respiratory events are more easily seen in that particular channel. Like if they were to have issues with snoring, upper airway resistance, that type of thing. So that's why we use two. They can fail, you know, like maybe the cannula is sensitive. So sometimes when you have the cannula just inside the nose, the little prongs kind of like hit the patient's inside of their nose and occlude itself, and you might not get a great reading. It's not one of those things where I'm going to keep running in to wake the patient up to play or like ever so slightly adjust that. If I've got a really good quality thermal sensor reading, then I'm not going to wake the patient up. I'll just go with that one for the time being until they wake up themselves on their own. So we do have redundancies in what we place on the patient because this isn't a perfect test. There's things that are going to fail, and we really have to weight the importance of, Is it worth going in to fix versus the detriment that it's going to have on the patient's sleep? And it's going to have that detriment in terms of the quality of what we're seeing, like the quality of the data. If we're continually waking them up, we're not going to get an accurate picture of what they typically would do during the night. So we do have redundancies. Here's an example of what it looks like. We typically will kind of tie together the thermal sensor and the pressure transducer cannula. This one is hanging really low. Like, I think they did it just for demonstration purposes for the picture. It would normally be like right up there in the nose. Different cannulas are sometimes made for different thermal sensors. Like, there's ways to and techniques to kind of tie them together so it feels like they really only have one thing on, and it helps they both kind of hold each other in place. What you're looking at here, those are the eye electrodes, the chins, but these chins weren't placed correctly because remember, you need one on top and then two on the bottom. They put all three on the bottom. The belts. We monitor the patient's effort to breathe through belts. One goes around the chest, one around the stomach. They need to be snug, but not uncomfortably tight. Like, we don't want them to be so tight that it's like they feel like they can't take in a deep breath. We also don't want them so loose that they're just falling. We want them to stay in place where we put them. The chest one is going to kind of go right underneath the armpits, like right above the chesticles. And then the belly one is going to go right around like the belly button area. They will move throughout the night, but try to take care to like make them snug enough so that they kind of stay for the most part where we put them. How we measure the respiratory effort is through a technology known as plethysmography. Plethysmography is a term that's going to keep coming up in sleep. And the actual definition of plethysmography is a change in volume. And so we use this kind of technology, detecting a change in volume, in a few of our different sensors that we use. But for effort, if you think of the belts, what they're picking up is the change in the volume as your stomach and your abdomen change and as you're breathing in and out. So it's detecting that change as the belts are stretched as you breathe in and as they loosen as you breathe out. So it's a very sensitive technology because you're thinking like, what if I breathe really shallowly? Is it even going to pick it up? And it does. It's a very sensitive method of how we do it. So there's 3 different kind of technologies that we can use to monitor the patient's, the change in their chest and their abdomen, the plethysmography of their breathing. There's elastic belt tension, electrical impedance, and electrical inductance. And I'll explain the technology of those 3. So tension. Tension is essentially like you have just a strap of fabric and it's connected to the belt or to the sensor itself, to the clips that clip together. And so as the person breathes in and out, it kind of pulls on the sensor itself. So it's basically like based on the tension of the belt going around. And it's the belt itself going around is just a strap of fabric. Where the actual sensor is in the clip itself. These use a piezoelectric sensor, same thing as the thermocouple. So it generates its own electricity, so they don't have batteries or anything like that. These used to be the standard of the belts that we used in sleep. They worked good. I liked them. You didn't have to finick with the belts too much. You got them on as long as they were snug enough to stay in place. For the most part, you saw what you needed to see. Issues would come up if the patient were like sleeping on their side and like really hunched over and the center itself was kind of shifted, so you didn't really get to see anything too much, or if they laid on their belly, like if they were laying right on the sensor. And it's not like every time the patient changes position, we're going in and adjusting those belts. We want to minimize how much we go into the patient's room. Because of that, the sleep world and the standards that we go by has shifted, where we no longer typically are using this technology for a standard sleep study. I go over it because you need to know it and because you will still come across it. What's funny is like we got away from using these. The AASM, or American Academy of Sleep Medicine, are the ones that set our standards by how and what and all of our practice standards for how we do everything. And so they required that labs make the transition from these piezo belts to the RIP belts. which I'll talk about next. But it's crazy that now sleep labs that are doing sleep studies on patients that get the implant. Have you guys seen the commercials for the implant for OSA? I heard one on the radio and they're like, oh, do you have OSA? And blah, blah, blah. And then they like talk about it's not this device. They don't even ever actually mention it's an implant on the radio. So you've probably heard it, but you don't even realize that it's for an actual implant. So it's kind of the biggest and newest wave that's happening in sleep medicine right now is there's an implant that patients can get to treat their OSA. And it's just like a cardiac pacemaker. It's where it's placed underneath the skin. And it's got two wires. One goes to like their intercostal muscles to pick up their breathing, and one goes up to their vagus muscle that moves their tongue. And so essentially when they sleep, they wave this wand over the implant and it activates it. And every time they take a breath in, it activates their tongue and juts their tongue forward. So if they're awake, every time they breathe, it's just like, ugh, ugh, ugh. You should Google it because St. Peter's did a little news story, or I think News Channel 9 did a news story on the first patient to do it, and he's a St. Peter's employee. And you can see him as he's awake, and he's like, just his tongue keeps just jutting forward. We do studies on these. This is like the newest wave that you guys will see in the sleep lab, which is really cool. And your medical director, the medical director for this program, is the one doing them in this area. So she'll come and talk to you guys about them too next fall. But basically, long story to get right back around to where I was going. When we do sleep studies on these patients, we now have to use the piezo belts. Like we're going back to this old technology because the belts that's the standard of care that we typically use, the electrical magnification, because it's an electrical field that it creates around the patient, we can't use with the pacemaker. So we have to use these older ones. And it was really crazy. Like Erica, who a lot of you met yesterday, one of the adjuncts here, she manages the Albany Med Sleep Lab. So when they started doing their Inspire, it's called Inspire is the implant. When they started doing the Inspire patients, she didn't even have any piezo belts and she didn't even know. And I was like, until I told her when she was here. And so luckily I had some, because labs kind of, when they get rid of their old equipment, a lot of it lands here that we can use for you guys. So I ended up giving her a few to use because it's like this older technology, but it's making a comeback. And I never had issues. Like all the bad stuff they said about the piezo belts, I always got really good signals from them. Impedance plethysmography. So these are really big words. I know that. Break them apart. So plethysmography, again, it always means a change in volume. Impedance is like resistance, right? Two terms used interchangeably. Essentially, what we're doing with this is two electrodes are placed on the opposite sides of the chest. And as the patient breathes in and out, it's picking up the resistance between those two electrodes. So as a person breathes in, the resistance increases because there's more distance between them. As they exhale, the resistance decreases. Get it? It's very rudimentary. I've never seen it done in the sleep lab. Mainly used on babies, but honestly, they make belts now that are baby size. So we don't necessarily have to do this because it can, you don't get the most accurate reading, but it's still an option. Okay. Our gold standard, respiratory inductive plethysmography, or RIP. Again, hint, 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 make sure you know what RIP stands for. So if I ask a question like, what's the gold standard for belts? And I write inductive plethysmography, right? I just gave you a test question. Respiratory inductive plethysmography. How you know your belt is this technology is you'll see the zigzagging wire and it goes throughout the entire length of the belt. So essentially what happens with these belts is we are creating a, yeah, that's what it says. We're creating a magnetic field around this patient with a zigzagging wire that is it's coiled within the belt. You see that. And so as the patient breathes in and out, that change in the magnetic field on that wire will change. Again, it's picking up the change in the volume. And so that's how it's able to pick up the patient's effort to breathe, is it's with that coiled wire, it's picking up the change in the volume of air of that coil of wire. Okay. So there's 3 different methods that we can use. Remember, there's the elastic belt tensions. Those are your piezo crystals, and it's just a single crystal. So the belt itself is just a strap of fabric, and as the fabric stretches, it pulls on the sensor where it's clipped in. You can do impedance plethysmography, which is 2 electrodes, and it's picking up again the change in the volume as the person breathes in and out, the distance between the electrodes move as the person breathes in and out. And then you have inductive plethysmography, which is this coiled wire that's creating this electrical field around the patient, around their chest and around their abdomen, and it picks up the change as they breathe in and out. Our gold standard is the RIP belts. Funnily enough, this picture, she's wearing piezo belts. Don't tell anybody. I think I got the wrong picture. So the difference between RIP belts, piezo belts, if you were to just look at them, they could look pretty identical. RIP belts, though, have that zigzagging wire. That's how you know it's a RIP belt. Piezo belts, it's just a strap of fabric with some Velcro on it so you can change the tension on the belt itself. The sensing element for RIP belts is the zigzagging wire that runs the entire length of the lead, whereas the piezo belts, it's just that the clip where the belts connect. That's where the sensing element is just that particular clip. For the most, RIP belts work regardless of whatever position the patient's in, anything like that, versus the piezo belts, could get a little wonky when the patient's on their belly or when they're, laying kind of really hunched over and not getting a great tension on that sensor. Advantages. So there's no electrical current that actually passes through the patient's body. So if the patient has a pacemaker or anything like that, like a heart pacemaker, we do not need to, switch up what we're applying to the patient. We can still use the RIP belts. Versus impedance plethysmography. Remember, you're putting 2 electrodes on the skin and it's setting a current through from one to the other to pick up the resistance between them. So, those you do have to be careful on patients that have any type of implanted device. RIP belts can be a little sensitive to the tension. So you do want to make sure you get the tension right. And you don't want to make sure that they are like really, you got a lot of loose slack. So the mechanisms to change the tension, you guys are all going to struggle with it when you first pick up those belts because they've got 2 little like sliding things. And then you watch me show you and then you're like, oh yeah, that's easy. And then you try to do it and it's like, not the same. Versus the piezo belt, it's literally like a strap and you snug it up and you Velcro it onto itself. Very easy to adjust. The RIP belts, you got to kind of take some finessing and you got to get used to them. So you got to make sure you don't have like a lot of slack, like, the extra of the belt. It's truly, you use those mechanisms to keep them flat against the body versus having like loops of the belts kind of hanging because it's not going to work right. Some other things that you might see, mercury strain gauges, which would be like, you put, again, like a belt around and it uses mercury. So you don't see that at all anymore. I talk about some of the historical stuff because you still might come across it on your boards. And then intercostal EMGs. What are your intercostal muscles? Between the rib cage, yep. So they're your accessory muscles of breathing. What's EMG? Electromyography, yeah. So if you take, I know, like we're talking about some big words here, but if you kind of break it apart, intercostal, that's your intercostal muscles, your accessory muscles of breathing. EMG is electromyography. It's picking up your muscle tension. So what are these doing? We're placing them on the intercostal muscles. We're placing a couple EMG electrodes, just like we put on the chin or on the legs, on the intercostal muscles. And that can pick up respiratory activity as well. The issue is that you actually have to find between the ribs. Like you kind of have to have the patient lean over and you kind of palpate their ribs and find a good spot where you can kind of get between the ribs. A lot of our patients, you can't do that. A lot of our patients are obese. So finding some ribs can be really difficult. So it can get a lot of artifact, especially depending on how much like body matter you're trying to go through to get your signal. Very inexpensive though, like a really quick, cheap, easy way to get the respiratory effort. So I'm dating myself a little bit, but when the labs first were required to make the switch from piezo belts to RIP belts, one set of RIP belts, meaning one chest and abdominal belt, is $400. Everything we use here is wicked expensive. So please just tender hands. Obviously, some of the labs couldn't afford to replace all the belts all at once. They had to do it transitionally. So sometimes, like some rooms had RIP belts, some rooms still had piezo belts. What we had to do is the rooms that had piezo belts, the ASM required us to also do intercostal EMGs, just to kind of have that extra added layer of monitoring the patient's respiratory effort until labs fully made the switch to the RIP belts. You still might have to do it. I still know of some labs that do use intercostal EMGs, okay? So don't just completely write it off in your head that it's something you'll never have to come across. Mercury strain gauge, you'll never come across. Nobody uses mercury anymore. Intercostal EMGs, you might have to do it. And it's literally the same technique as how you're gonna put on the leg leads or the chin leads in terms of prepping the skin. You're just finding a different muscle. Esophageal pressure is a monitor that goes into the patient's esophagus. It's very invasive, very uncomfortable. We do not use it in a routine sleep study. It has to be placed by a physician. Like, I don't even train you guys how to do it. I've never seen one. I've never put one in because it's invasive. Essentially what they're doing is they're putting something down into the esophagus and then inflating a balloon. It's incredibly accurate. What I'll do is when you guys get to this point next year, we'll go through scoring and I'll show you like some of the minute breathing changes, because as sensitive as all the equipment is that we put on the patient, it's not as sensitive as it could be, which means that the esophageal pressure also is so sensitive to like the minute, very like tiny little changes in upper airway resistance and everything. It's incredibly accurate. It's incredibly sensitive, but it's very uncomfortable. So it's not necessary to put our patients through that for a routine sleep study. You'll really mainly see it for like research purposes. Pneumotachometers or pneumotachographs. So you remember that little side room that we were in? We have the main lab, the side practice room, and then that other office. Do you guys remember that when we were in lab last time? And that had that big box. Probably didn't pay much attention to it, but it had a big box with a chair in it. That's a PFT or pulmonary function machine. And it does similar to what a pneumotachometer does, which basically you have this like very precise airtight environment or like that thing is, and it measures the exact volume of air that the patient is breathing in and out. Not something necessary for the sleep study, but it is another measure of respiratory. Capnograph or end-tidal CO2, that is our exhaled carbon dioxide. Again, mainly used in pediatrics because we need that additional kind of sensitive marker for the changes in the patient's breathing. It's sometimes you'll see it as EtCO2, PetCO2, ECO2. It all means the same thing, end-tidal CO2. Capnograph is the actual, the machine itself. It's another cannula that goes underneath the nose, very similar to the nasal pressure transducer. So typically what we'll do for kids, so we're not stacking stuff inside their nose, we're not gonna have the nasal pressure cannula and the end-tidal cannula and the thermal sensor, because no kid is gonna leave that alone. They're just gonna rip it right out. We have these special cannulas that are dual-ended. So it's the single cannula, one end connects to our nasal pressure transducer, one end connects to the capnograph. So it's a single thing that goes in their nose, but we're able to connect it to 2 different devices to get both readings that we need to get. Transcutaneous CO2, essentially what that is a patch on the skin, and it warms, it's got like a heating sensor, so it warms the skin, so it's able to pick up how much CO2 is in the blood that's directly underneath where the patch is placed. Incredibly expensive, so not a ton of labs use it. It's safer now. It used to be too. A lot of labs like that do pediatric studies were really scared about doing transcutaneous because you could burn the patient if you weren't careful. And so they didn't even want to like start that. Whether or not we have, because you'd have to go in every few hours to change where the patch is placed to make sure that the patient doesn't get burned. And so it's like, if I have to go in there every few hours anyway to wake the patient up to move it, what difference is it if I'm going in there every few hours to adjust the cannula because the kid either snots it up or pulls it out or whatever. So the newer versions though are a lot safer, where you don't nearly have as much of a risk of burning the patient with it. Accuracy decreases when the skin thickness increases. So kids, babies, their skin is very thin. We get a very accurate reading. We're not going to get as accurate of a reading on adults. It's, you know, as you get older, your skin gets thicker, so it's not really not going to work too well. Snore microphones and sensors pick up a patient's snoring. The sensors record the vibrations, and it picks up, and you see that you're able to read it by looking at the amplitude difference of the signal. So like, just like with muscle tone, when a muscle tone increases, you see a jump in the EMG signal. Same thing with snoring, you'll see it increase, and the size of the increase kind of really relates to the severity of the snore. The microphones pick up the noise. So you can, it depends where I've had some where like you put it kind of on their forehead where it's coming down and it'll pick up the noise. Just something to kind of get it out of the way. Sensors, like I said, are the ones that you'll probably come across most often. And they're just like these little discs that you tape right to the neck, and it just picks up the vibrations of the snoring. So sometimes because you're picking up the vibrations, it can pick up this upper airway resistance happening with a snore that might not be like audible yet. You might not be able to even hear the snore, but that sensor can pick up that vibration is happening. Basically, how you put this on is, you just, let the patient know before you touch them. You got to tell them what you're doing every time. But, you say, I'm just going to feel on your neck, and I'm going to have you cough, or I don't really like them having them cough because I'll just have them say 1, 2, 3. And wherever you feel the vibration the strongest is where you're going to tape this little disc to. Avoid the arteries, because if you place it right over the carotid arteries, you're going to get a ton of EKG in your bounce in your signal versus, you'll have to kind of read through the beat of the heart to see the sonore. So you can kind of like avoid the artery and go a little further. Even if you felt the vibration strongest here, go a little further out to avoid the artery. We monitor everybody with cameras. Every sleep study, every patient is monitored via camera. We make the patient aware of that as soon as they come into the room. Depending on what lab you're at, some cameras are not turned on until we start the sleep study, until the patient's ready for bed. Some labs have you start the camera as soon as the patient is in their room. And that's for safety, to protect the patient, to protect you if they try to make any claims. I've worked at labs that do both. As soon as the patient's in the room, I've got to start the recording going, so they're audio and visually recorded with the camera and with the intercom. Every lab has an intercom system, whether it's through the computer or whether it's like a legit old school style box on the wall, so that we can hear the patient. Kind of depends on what lab you're at, whether or not the intercom stays on all night, where you have to listen to them. Or some labs have like a call button. So if the patient, so you can turn the intercom off and they just like hit a button when they need you for something. That's nicer. So you don't have to like listen to them snore all night. Oxygenation, pulse ox. You guys know what this is, right? Do I need to? Okay. Generally, it goes on the finger, any 3 of the middle fingers of the hand. Sometimes kids and stuff, I will use the thumb. Not supposed to, but sometimes it just fits better and it's less irritating because less nerve endings on your thumb. So it doesn't get as irritating as quickly. With kids, I'll go on the toe, I'll go on the foot, especially like the toe, and then you can put a sock over their feet if they like keep pulling on the finger probe. Plethysmography, what does it mean? What? Say? Yeah, sorry, I can't hear as well because these things are covering my ears. But what's really disconcerting is when one of them talks, it's like in my ear and you can't hear it. Yes, change in volume. So what's happening with the pulse oximeter is a lot of our monitoring systems have a plethysmography channel that correlates to the pulse oximeter. which means it's picking up the change in volume of the blood. And it's essentially reflecting like the heartbeat. It's this tiny little waveform. It looks very similar to how like the respiratory channel comes through, but it's a lot smaller and it's a lot quicker. And so it's one of the ways, very similarly to like when you guys put your finger pulse ox on and you see that pulse beat happening and you got to correlate it. Same thing on our sleep system. You see this little waveform and it pretty much will correlate with the heart, with the EKG. If it doesn't, if it's like gotten flat or it's not coming in really great, you know that your signal isn't accurate. You need to go in and check where the pulse ox is, make sure the patient's not like laying on their hand or anything like that. What's really nice is like if you're doing a different type of study, like a home sleep test, we don't monitor everything that we would monitor for an in-lab sleep test. We don't monitor the EKG, but you can kind of pick up if there was EKG issues by looking at the pulse ox plethysmography channel. Because again, that little waveform represents the heartbeat. So you can kind of see if it's irregular, like if there's like all of a sudden a skip beat, versus if it's kind of pretty consistent, you'll see it's like generally a pretty decent EKG channel. And that's what it looks like. Again, just like this tiny little waveform. So if you can see it flatlines, if there's a skip beat or an irregular heartbeat, or if you're not getting like a great signal, especially if you've got like a pulse ox reading that you're questioning, like say it's low 90s, upper 80s, like, is that really the patient? Because sometimes their baseline when they're asleep is that low. And sometimes it's like, man, or did the thing just slip ever so slightly? Is it worth going in to wake them up? Well, look at your plethysmography channel. If you're getting a nice strong signal in that, then yeah, that's probably an accurate reading, versus if you're getting like a weaker signal, something like that, then you need to go in and fix how it's on the finger. How you guys doing? Keep going? Finish it up? Actigraphy. Actigraphy is a non-invasive method of monitoring the patient's movement. So just like how you guys just kept the sleep diary for about a week and you kind of kept track of your sleep and your wake cycles, actigraphy is a objective way of doing that. Your sleep diary is subjective. It's reliant on your honest reporting, your ability to comprehend when you're awake and when you're asleep. Actigraphy, a lot of you have it. It's like in the smartwatches. It's picking up your movement. It's a very common technology nowadays, but they do make ones that are specifically for sleep that pick up the patient's rest activity cycles. And it's typically worn like a watch on their non-dominant arm, and it can pick up. It's really good for like patients that have like a sleep schedule disturbance. Like say we think something, they might have an insomnia where they're not sleeping, or whether they're having some type of circadian rhythm disorder where just the timing of their sleep is really off. This can pick up over a long-term period, like up to a week to 2 weeks, what their sleep wake cycle looks like. The data is limited. It's literally just picking up their movement. But you can pretty much see like when there's no movement, they're asleep, and this person is pretty consistent with their sleep and wake times, versus somebody that had insomnia or a sleep schedule disturbance. You'd see it be like really kind of skewed as well. This isn't used nearly as much anymore as it once was, because the device itself is incredibly expensive. Sending it home with a patient for up to a week, you're not going to be able to get as many patients using it. And then you run the risk of getting it back. That's what we run the risk of anything that we send out with a patient, is getting it back and getting it back in working order. So it's a very expensive little technology piece that there's not a lot of reimbursement for even doing this on this patient. But it is an option in terms of patients that have circadian rhythm or sleep schedule disturbances, insomnia, difficulty sleeping, and people that doing an in-lab sleep study could be really difficult, or if patients like think they kick a lot to do limb movements. The electrodes that we apply for the scalp and the face are what's known as cup electrodes. These are the ones that we have to use the paste to affix. The electrode paste, like it's in a tub, the 1020 or the tube of Elafix. Typically, they are what's known as gold cup electrodes. So they are gold plated on the end because gold is a really good conductor of electricity. We use these ones for all the ones on the face. So there's 15 in total between all of our brainwave ones, the ones that go on the face. Essentially, like, you can get these electrodes in different kinds of metals. Electrically, it would freak out if you use differing metals. So you want to try to make sure that when you grab the electrodes or when you are using them back there, for the most part, all the electrodes that I have back there are the same type of metal, but some of them are different lengths. So try to keep the lengths consistent with each group of wires that you're using. And that's how you place those on the skin, on the scalp and on the skin as you use this paste. And what this paste does is it electrically insulates the electrode and helps the electrode pick up the electrical activity that over which it's being placed. So if it's on the scalp, it's picking up the brain waves. If it's by the eyes, it's picking up the electrical motion of the eye muscles, or of the chin muscles. And so what it does is it helps the electrodes stick in place, because it's just like, you're not just going to like set a metal wire and hope it stays in place, because it won't. This stuff is thick and it's creamy. It's like a Play-Doh-y. It's thicker than a cream. It's probably like a little bit thicker than like frosting, in terms of how thick it is. And so it helps the electrodes stick in place, and it helps it pick up an electrical signal, and it also will electrically insulate it from other ambient electrical activity that could be happening in the room. Snap electrodes are the ones that you use with your snap stickers. So those little stickers that have that little metal button on them, the little metal button attaches to the back end of these. So if you've done EKG, you've probably seen them before. We use these for the legs and for the EKG. Some labs you can also use them for the face, but not here. In most labs in this area, you use gold cups for all of the face and all of the head. How we apply is very similar in terms of how you're prepping the space that you're applying these electrodes, whether you're using gold cup or snap electrodes. So the full setup, we're putting on a lot of different things, and it all plugs into this one single box that the patient is mobile with. You can move around with all the wires on. So like, once the patient's in bed, they don't, they can get up, they can go to the bathroom. We're not taking everything off for them to use the restroom. They just kind of go with, I call it their leash, where everything's plugged in. And they usually have like a strap that they can throw over their shoulder or throw on their neck, so they can move around with all the wires on. There is a method to the madness for how you put on everything, because you do need to make sure that you're putting it on in a way that it stays secure, but also the patient's safe. They're not going to tangle themselves in everything, and they're not going to, like, just them moving around, they can rip stuff off. So there's a method to the madness in how we put it on and how we kind of bundle the wires together. We use these little like ties to keep the wires all together, to keep them secure and they don't tangle. So the basic supplies needed for an application is you're going to need gloves. You're going to wear gloves when you put them on. And this is pre-COVID, obviously, everything else that you guys got to wear in lab. You'll need scissors for cutting your tape. I do have scissors here. The tape that comes in your kit is a very skin sensitive tape. I don't know if you guys have played around with it yet, but it's a cloth tape, because everything we're putting on the patient needs to stay on for upwards of 8, 9, 10 hours, however long they're sleeping for. So we need to make sure that we're using the most sensitive of stuff that we can use. So the tape is like a cloth-based tape that their skin can breathe through it. Anytime I've had a patient tell me that they have an allergy to tape, usually just asking them like, okay, what's the nature of your allergy when you had like a sensitivity to an adhesive? Usually you get down to the root cause of it, and it's because like somebody put on silk tape on their skin, which is like this really tough, very sticky tape that's not really meant for skin, and then they left it on for days on end. So anybody's going to have a reaction. Most patients do perfectly fine with our tape, especially like it's cloth, which is nice. We can saturate it with a skin safe adhesive remover to take it right off, because it's usually not the tape itself that causes the irritation, it's taking it off. So like, we can easily take it off very gently. Tape measure, that's, you guys have already familiar. We're using the same thing that we measure the neck with to measure the head, to be able to figure out where we're applying the electrodes. The grease pencil or the wax pencil, I think it's red in your kits, right? It's also, sometimes you'll see it referred to as like a China marker, because you can write on plates and stuff because it's a wax-based pencil. That's what we draw up on the scalp. So as we measure and mark the head to figure out where we're applying the electrodes. The conductive paste, you have 2 different types in your kit. You're gonna start playing with both, see which one you like better. Alcohol swabs, skin prep. So that's the green stuff. It's called New Prep. If you were to actually squeeze a little bit out on your finger and feel it, it's pretty gritty. So what we do is we use that to kind of prep the skin, slough away any dead or dry skin so the electrodes get as good a contact as possible. We use the cotton tip applicators to do that, so you're very precise in where you're cleaning. Hair clips. Hair clips are not in your kit, but they're an option. I have some here. And when we get to the point of manipulating the hair and stuff, I kind of leave it on you guys to figure out what method you like best because there's so many different ways here. So that's why I didn't include hair clips because you might like the butterfly style clips to clip the hair up. You might like I don't know, those claw type clips, whatever. You might like different sizes. Just go to the dollar store once we start working on that and you figure out what works best for you and get a little baggie to bring your own hair clips. Because we do need to make sure that, when we're measuring the head, when we're applying the electrodes, it goes right onto the scalp. Like we're not applying electrodes on hair, we're parting the hair to put it on the scalp. And learning how to manipulate the hair so you're able to find your marks that you made, your measurements and everything is a skill that we'll learn this semester. You can use a comb. I don't comb the hair personally. You can spend a lot of time trying to like undo their snarls, but what I will use is I get one of those combs that have like the pick at the end, because really all I want to do is part the hair. And so I use that pick to kind of just like easily part the hair where I want it. And then gauze. So the bigger gauze pieces that you have, the 4x4s we mainly use for cleaning. The little 2x2s we mainly use for affixing. So the electrodes that are placed on the scalp, you're placing them, they're the gold cups, you're using paste and you're not gonna tape them. We're not taping anywhere where there's hair. What you're doing is you're taking another second piece of gauze with more paste on it and you're sticking it on top. The paste itself does not harden. It stays the same consistency throughout the night. If anything, it'll like soften up a little bit as it gets warm from the patient's body heat. But for the most part, they're really secure just by using a little bit of paste and then another gauze pad with more paste. You will be messy because you're all going to be practicing on each other. So I'm saying we're not just starting the head this week, we're starting the body wires. But when we start the head next week, you guys will be messy. So I would recommend not washing your hair because dirty hair actually is easier to manipulate and move. And you're going to be needing to wash your hair as soon as you leave here anyway. So no product. Bring only what you need into the patient's room that you need, because we don't want to bring like our entire tub of paste or entire sleeve of gauze, because again, think of cross contamination. You want to just grab what you need and then put everything else away. What I've seen in the past that really works for your application supplies from your kit is getting like one of those rolling hanging toiletry kits, and you can kind of put them all in that. And then because when we're doing application, that's really all you need. When you don't nearly need to bring everything else in your kit. The EKG stickers, you only want to count out how many you need, put the rest of the bag away. Because if you're in the patient's room and you drop an EKG sticker and you need another one and you reach into the bag with dirty gloves, well, you've just contaminated that entire bag, right? So avoid even that temptation. Only what you're going to learn how to do is set out exactly what you need for exactly the task that you're doing, and then you're going to put everything else away. So you do need to start learning how to be familiar. You're going to become familiar with the equipment that we're going to use, because we need to be able to explain it to the patient. We got to explain not only what it does, what it's looking for, how we're putting it on so they can anticipate the process. Again, remember, you guys are all new to this, but in short order, you're going to be really familiar with it, and it's going to become second nature to you to be doing all of this. So remember that feeling that you have now of the unfamiliarity, because that's every single one of our patients that we deal with. Oftentimes they come in for this very nervous. They're sleeping in an unfamiliar place, they're sleeping away from their family, without their usual comforts of home, and not even knowing what to expect when they come in and what we're going to be doing and whether or not it's going to be painful or whatever. So the first 5-10 minutes I spend with the patient before I do their vital, sometimes you do the vitals as you just walk them in, but I'll just be explaining everything. Like, this is what we're going to do. These are the wires. This is what I need from you. And I can't tell you how many times in that first initial interaction, you just see their face kind of relax, and I've had them tell me like, wow, I was really nervous about this, but it ain't no thing. Well, I've never had a patient say that specific, but like, you get the deal. So just being able to kind of explain it to them. So here's a bunch of review questions, which you can do. So before the patient arrives, what you're going to do is read through the chart, familiarize yourself with the patient. We want to make sure that we're doing the specific test that's best going to benefit that patient, and also that we have become as familiar with the patient as possible in terms of being able to anticipate what we might see with the patient, or what extra safety precautions we need to do for the patient. Review your order form, make sure that's accurate, make sure that it matches up with the instructions and from what you read in the chart. So before the patient even arrives, we know what study we're going to be doing, we can prepare for it. You're going to check the patient's room, especially if it's your first night on. You're going to want to check for cleanliness, depending on what texts. Sometimes you get to know who you're following. Some people are sloppier than others. So, I'll check to make sure the room is clean, the bed is made up, I got everything I need. I'll set out my equipment. I personally like to lay all my wires out across the bed very methodically. If you guys didn't pick it up already, I'm pretty type A. So I like everything very methodically laid across the bed. What that does for me is it has all the wires kind of splayed out. So when the patient does arrive, they can see everything that's going to go on them, and it prevents them from getting into bed. It prevents them from climbing into bed before I'm ready for them to climb into bed. So they know you're not just here to just climb right into bed and go to bed. There's a process before that can happen. And not everybody understands that. That's not to say I haven't had some patients, a couple times, they just took my wires and they just like bundled them, threw them at the end of the bed, and then just climbed into bed. And I did not lose my shit, but internally I was screaming. The other component for me personally, by laying everything out, is it makes my application so much quicker because I'm so methodical with how and where I lay things out. I'm not doing as much like back and forth to go grab wires, walking around the patient, like everything is, so my setups are typically about 20, 25 minutes. So a lot of that is my prep work. I have as much done ahead of time before the patient arrives. You don't know how exhausted the patient's going to be before they get there. You get some people that are just like begging to go to sleep. And if you're taking upwards of an hour to apply all these wires, you've got them falling asleep on the chair and that's dangerous. I've seen it happen to other techs where the patient actually fell out of the chair because they fell asleep. And, that's a whole bunch of write-up we don't want to have to deal with. You also don't know how unpleasant or unpleasant the patient is going to be. Like if you don't want to spend an hour in the room with them, doing a swifter setup is ideal, or how bad they're going to stink. Like I've had patients where they stink to high heaven. So I just want to be as swift as possible applying these electrodes to get out of there. I set up my cart, I set up all my equipment. So everything is as ready to go as possible. Set up like, your paste and your tapes and everything, like cut them to size how you'll need them. Once the patient arrives, you're going to go through whatever necessary paperwork you got to do with the patient. Either collect or go through their sleep history questionnaire. Most labs have some type of consent that we have to have the patient sign. Usually it has to do with the videoing and the monitoring and stuff, so the patient is consenting to the study. And then most every lab has some sort of pre-test questionnaire or pre-sleep questionnaire, which essentially is asking them about their day, how much sleep they felt like they got in the night before, how much caffeine they had during the day, did they exercise more or less than usual? And it's really kind of giving us a good idea of, or a snapshot of how the patient's day was coming into the sleep study. Patient education, I'm huge on this, helps really build that relationship of trust with the patient, helps them feel more comfortable with this process, because it does not need to be a nerve-wracking process for them. It's a non-invasive test, and it can be a kind of fun experience, like especially when I do pediatrics. I make sure I'm like, I up the excitement level, like, you ready for your sleepover? We're gonna like put some wires on you. You're gonna be like my little puppet, get some hair jewelry in there, get some really cool, colorful dreads. You know, so it can help the patient where it doesn't have to feel like this very serious diagnostic test. Um, Taking the time to educate them about the importance of good sleep, about the importance of putting sleep first, of untreated sleep apnea. So, you know, I generally don't talk to them like about specifics, like I'm not giving them their results, I'm not diagnosing them. I talk about it more in generalizations about, you know, like, so in all likelihood, this test, one of the big things we look for is obstructive sleep apnea. Have you heard about it before? No. Okay, let me explain that and how important it is if it is found that you're positive to follow back up with treatment. We document throughout every step of the process, and it's a part of your final report. I know we've talked about documentation. It's important to not only protect you, protects the patient. The physicians rely heavily on our documentation to help get an idea of what happened throughout the night, to kind of get that extra piece beyond what the wires and what our signals will tell them. At the mornings are generally pretty quick, which is nice because you're really exhausted at that point. Basically what we do is in the mornings we take the wires off. There's usually a few things the patient has to complete in the morning. One of them is a post-sleep questionnaire or post-test questionnaire. It's similar to the pre-sleep, but it's basically asking them how they felt the night went. How much sleep did you feel like you got? How did anything really disrupt your sleep aside from the wires, obviously? And that gives us an idea of, is the patient an accurate um, discernment of their own sleep? You know, if we recorded like 8-9 hours and they're saying, oh, I only slept 4 hours. Well, okay, I'm starting to see where some of the mismatch is in terms of how much we can rely on them being an honest reporter. You cannot give any information from the study. You're going to get patients that'll ask you, they'll beg you, they'll offer to buy you breakfast. You cannot give them any information. And they can get nasty about it too. Like, well, I know you know. Like, well, yeah, I do know. I just ran the study. I would hope I know, or else you just had somebody run your study that didn't know what they were doing. But I'm not telling you. And they can get nasty about it. And you can get in a lot of trouble if it's ever found that you did give them any information. They always find out. Doctors always find out.